Hello everyone, this is Dr.Manikanta, currently doing DM gastroenterology from AIIMS. Today we are going to discuss regarding the ST-related myocardial infarction ECG interpretation. By the end of this lecture, you will be able to identify the what is the artery that is blocked and what is the site of artery that is blocked without angio by simply by the ECG. Okay. Before we begin the session, please do subscribe the channel and like the video. Let's begin the session. Let's start the Stemi ECG interpretation. So what is MI by the way? Myocardial infarction, it is due to total occlusion of the coronary arteries, right? What are the two basic types of MI we have? Stemi and NSTEMI. Can you tell me what are the few differences between the Stemi and NSTEMI? We have Stemi and we have NSTEMI. That is ST-related myocardial infarction. We also have NSTEMI, that is a non-ST-related myocardial infarction. So, of course, in ECG, what we get in case of STEMI is ST elevation. ST elevation. And what we get in NSTEMI is ST depression. Or what we can also get is normal ECG as well. Both can be seen, right? And STEMI is due to transmural myocardial infarction. It is due to transmural myocardial infarction, whereas NSTEMI is subendocardial infarction. It is due to subendocardial infarction. That is, only the subendocardium is infarcted, that is dead. Whereas in case of STEMI, the whole muscle is dead. That is called as transmural myocardial infarction. Here we have NSTEMI subendocardial infarction. Whereas in case of NSTEMI, subendocardial infarction, STEMI, we have transmural. If you consider this is interventricular septum, this is left ventricular muscle wall, LV, RV, right? If a whole muscle is dead, entire thickness of the muscle is dead, this is known as transmural myocardial infarction. If only the myocardium adjacent to the endocardium is dead, this is known as subendocardial infarction, right? This transmural produces STEMI, this subendocardial produces NSTEMI, right? Because of a transmural myocardial infarction, what we get is electrical window that produces what? Q wave. Remember that this is a previous year question repeated many times. Q wave is seen only in STEMI, but not, you do not see any Q waves in NSTEMI. Okay. And STEMI localizes the site of lesion, that is which wall is dead, that is infarcted. Remember, STEMI localizes the lesion, that is which wall is infarcted, whereas NSTEMI does not localize the lesion. NSTEMI does not localize the lesion, right? That means in case of STEMI, it is localizing the lesion. That's why we have anterior wall STEMI, lateral wall STEMI, inferior wall STEMI. But there is no such anterior wall NSTEMI, lateral wall NSTEMI. This is absolutely wrong. Just in diagnosis, we have to write only NSTEMI, right? Do not localize the lesion. Okay, that is anterior wall NSTEMI, lateral wall NSTEMI. This is wrong. For STEMI, we can localize it. That is anterior wall STEMI, we can write lateral wall STEMI depending on the ECG changes. Okay. By the way, what are the anterior leads? Anterior leads are V2 to V4 are anterior leads. Lateral leads are V5, V6, 1 AVL are lateral leads. Okay. Inferior leads are lead 2, lead 3, AVF are inferior leads, whereas the septal leads are V1 to V2. These are the septal leads. Suppose if you see the ST elevation in V2 to V4, we call it as the anterior wall STEMI. If you see ST elevation in lateral leads, that is V5, V6, 1 AVL, we call it as lateral wall STEMI. If you see ST elevation in inferior leads, we call it as inferior wall STEMI. If you see ST elevation in V1 to V2, we call it as a septal myocardial infarction, that is a septal STEMI. Okay. How much ST elevation is required, by the way, for STEMI? For STEMI, how much ST elevation is required? At least 1 mm is required to call it as a ST elevation, more than 1 mm. Exception is posterior wall STEMI. In case of posterior wall STEMI, that is ST-related myocardial infarction, even 0.5 mm ST elevation is considered as pathological in posterior leads, that is V7 to V9. Okay. For STEMI, in any leads, even more ST elevation more than 1 mm is considered as pathological, except in case of posterior leads. 0.5 mm ST elevation is also considered as pathological in case of posterior leads, right? Another exception is generally what we see is a physiological ST elevation is V2 and V3. Okay, what is the normal physiological ST elevation in case of V2 and V3? In case of female, irrespective of the age, ST elevation up to 1.5 mm is physiological, and in case of males, less than that of 40 years of age and more than that of 40 years of age. In males less than that of 40 years of age, ST elevation up to 2.5 mm is normal. More than that of 40 years of age, less than that of 2 mm up to 2 mm is considered as normal physiological ST elevation. Then when do we call it as pathological ST elevation V2 and V3? If the ST elevation is more than of these cutoff values, or simultaneously also shows ST elevation V1 and V4. Even then 1 mm ST elevation is also considered as pathological. Okay. So, suppose if a patient is having ST elevation only in V2 and V3 and it is 1 mm, then it is insignificant, because at least in females it should be more than that of 1.5 mm, in males 2.5 mm in case of less than 40 years, and more than that of 40 years at least 2 mm should be required, right? Suppose if patient is also having ST elevation V2 V3 that is only 1 mm, but is also having ST elevation V1 and V4 that is also 1 mm, then it is considered as pathological. Okay, right. Just few basics regarding the coronary blood flow, right? So this is left ventricle, right? From left ventricle we have the aorta. This is ascending aorta, this is arch of aorta, this is descending aorta. So what are the first branch of aorta, by the way? Coronary arteries. How many coronary arteries we have? Two coronary arteries we have. What are the two coronary arteries we have? Right coronary artery and we have LMCA, that is known as left main coronary artery, right? This is known as right coronary artery. By the way, what is third coronary artery? What is third coronary artery? I told only there are two coronary arteries, that is RCA and LMCA. There are in few individuals we also have third coronary artery. This is known as right conus artery. Third coronary artery is right conus artery. Usually the right conus artery is a branch of RCA, that is a right coronary artery only. Okay, this is actually first branch of RCA. However, in few individuals directly arises from the aorta. Let's discuss regarding the LMCA. This is LMCA, left main coronary artery, right? The LMCA has bifurcation and trifurcation. Usually bifurcation, that is bifurcates into LAD and LCX. This is known as left circumflex artery. This is LAD, that is a left anti-descending artery. The LAD continue downwards and gives rise to the septal branches. These are the septal branches supplying the interventricular septum. Then it further continue downwards and gives rise to diagonal branches. How many? 4. D1, D2, D3, D4. Then it continue downwards as distal LAD. Okay, this is distal LAD. This distal LAD supplies a what? Anterior wall of the heart, that is left ventricle. Anterior wall of the heart. Okay, these are the diagonal branches, it is D1, D2, D3, D4. These diagonal branches supplies a what? Lateral wall of the heart. They supplies a lateral wall of heart. Okay, these are the septal branches. These septal branches supplies a what? Interventricular septum, that is IVS, interventricular septum of the heart. Okay, suppose if there is a LAD occlusion, right, like distal LAD occlusion, here there is occlusion, that is a distal LAD, that is a distal to the diagonal branches, then which wall is involved? Right, I told what? Distal LAD supplies the anterior wall, that means the patient will have anterior wall STEMI. If a patient is having anterior wall STEMI, ST elevation seen in which leads? I told what? Anterior wall. What are the leads looking at anterior wall? It is V2 to V4. Okay. Suppose if there is a LAD blockage proximal to the diagonal branches but distal to the septal branches, that is here. Here it is distal to the septal but proximal to the diagonal branches. Then what will happen? The blood flow to the lateral wall is impaired, because blood flow to the diagonal branch is impaired. That means lateral wall is impaired, and also to the distal LAD is impaired. That means anterior wall. That means the patient will have anterolateral STEMI. So in which leads we get a ST elevations? Anterior leads, that is V2 to V4, as well as in lateral leads, that is V5, V6, 1 and AVL. So in case of anterolateral STEMI, EC change ST elevations are seen in V2 to V6, 1 and AVL. So where is the site of artery that is blocked? LAD. What is this artery that is blocked is LAD. What is the site that is blocked? Distal to the septal branches. Okay, distal to the septal branches, proximal to the diagonal branches. Okay, middle portion of the LAD is actually blocked here. So without angio also, by looking at ECG, you are able to know localize the artery that is occluded and the site that is occluded as well. Suppose if there is a proximal LAD occlusion here, this is proximal LAD. That means blood flow to the septum is impaired, blood flow to the lateral wall is impaired, blood flow to the anterior wall is also impaired. That means the patient will have anteroseptal lateral STEMI. Anteroseptal lateral STEMI, ST elevated myocardial infarction. This is known as extensive anterior wall MI. Extensive anterior wall MI. So what are the anterior leads? I told V2 to V4, lateral leads V5, V6, 1 AVL, septal leads V1 to V2. That means we get ST elevation in V1 to V6 along with 1 and AVL. This is known as extensive anterior wall STEMI. Where is the site that is occluded? Proximal LAD occlusion, correct? Right. So let's discuss also regarding the L6 as well, left circumflex artery. Okay, right. This is L6. I told it bifurcates into L6 and LAD. This is L6, left circumflex artery. The left circumflex artery winds around the heart and enters a posterior atrioventricular septum, supplying the inferior wall of the heart. This portion supplies the inferior wall of heart. Remember that inferior wall of the heart is supplied with the RCA as well as by the L6 as well. Next, before winding around the heart, it gives us one branch which is known as obtuse marginal branch. This is known as obtuse marginal branch. Okay, just to remember only two branches regarding the L6. One is it winds around the heart, enters a posterior ventricular septum, supplies the inferior wall. Before winding, it gives us one branch supplying the lateral wall of the heart. This is known as obtuse marginal branch, right? Supplying the lateral wall. The lateral wall of the heart is also supplied with the diagonal branches, that is D1, D2, D3, and D4. Suppose if a patient is having only lateral wall MI, that is ST elevations are seen in lateral leads, that is V5, V6, 1, and AVL. In such cases, what is the artery that is occluded? Either it could be diagonal branches only, or obtuse marginal branch that is occluded. Or sometimes what will happen, there is a trifurcation of LMCA. What is the third branch of LMCA? Can anyone tell me? It is known as ramus intermediate artery. Okay, that also supplies a lateral wall of the heart, right? That also supplies a lateral wall of the heart. This is known as ramus intermediate artery. Okay, it is seen in 20% of the individuals. Therefore, lateral MI, only lateral MI could be due to obtuse marginal branch occlusion, diagonal branch occlusion, or ramus intermediate artery. Suppose if there is occlusion of the proximal L6, here is this occlusion. So what will happen? Blood flow to the lateral wall is impaired and also to the inferior wall. Therefore, what we get is infrolateral STEMI. Infrolateral STEMI means inferior leads are what? Lead 2, 3 AVF, we will get ST elevation, as well as in the later leads, that is V5, V6, and 1 AVL. That is suggest of proximal L6 occlusion as well. Right, the same thing I have discussed here. That is anterior wall STEMI. Where is the site of occlusion? Proximal LAD. Right, and extensive anterior wall STEMI means the patient is having anteroseptal lateral STEMI. This is anteroseptal lateral STEMI. Correct. So ECG changes are seen in anterior leads, septal leads, lateral leads. Anterior leads are V2 to V4. Septal leads are V1 to V2. Lateral leads are V5, V6, 1 AVL. Therefore, ST elevations are seen in V1 to V6, 1 and AVL. What is the site of occlusion? LAD only, but where is the site? Proximal LAD. Okay, what is anteroseptal, by the way? It is also proximal LAD only, but here there is no lateral wall involvement. Why there is no lateral wall involvement? Because of collateral circulation from the diagonal branch, collateral circulation from the obtuse marginal, that is a branch of L6. That's why the lateral wall here is spared. Therefore, we get ECG changes only in anterior leads, septal leads, that is V1 to V4 only. Anterolateral STEMI, again the LAD occlusion only, distal to the septal branch. Anterolateral STEMI, that is ST elevations are seen in anterior leads, that is V2 to V4, and lateral leads, that is V5 to V6, 1 and AVL, that is V2 to V6, 1 AVL. Anterior STEMI only distal LAD occlusion, that is distal to the diagonal branches. ST elevations are seen only in V2 to V4. High lateral wall STEMI, that is only lateral wall STEMI is due to obtuse marginal branch, diagonal branches, or ramus intermediate artery. These are the artery that is occluded. So ECG changes are seen in lateral leads, that is 1 AVL, V5, V6. Infrolateral STEMI, I told LCX, that is proximal L6. ST elevations are seen in inferior leads as well as lateral leads, that is lead to 3 AVF as well as 1 AVL. Okay, let's discuss regarding the few ECGs. Then we come to the inferior wall MI. So look here, where you are seeing ST elevations. Where you are seeing ST elevations here. Look here, we are seeing ST elevations in lead V2, V3, V4, V5, V6, 1 and AVL. Correct. So remember, V2 to V4 are anterior leads, whereas V5, V6, 1, AVL, these are lateral leads. Correct. So here we are having ST elevation in V2 to V6 as well as 1 AVL. That means it is a case of anterolateral STEMI. Anterolateral STEMI, ST elevated myocardial infarction. What is the artery that is occluded here? Anterolateral STEMI means LAD occlusion only. Where is the artery that is occluded? Proximal to the septal branch or distal to the septal branch? Distal to the septal branch, correct. It is a distal to septal branch, right? So this is LMCA, this is LCX, this is LAD. Here we have the septal branch, here we have the diagonal branches D1, D2, D4 supplying the lateral wall. This is distal LAD supplying the anterior wall, right? Here is the occlusion, that is distal to the septal branch. Suppose if it was proximal to the septal branch, then what will happen? We also get ST elevation is septal leads, that is V1. Here there is no ST elevation in V1. Therefore, it is distal to the septal branch, right? Without even angio, we are able to localizing the artery as well as what is the site of the artery that is occluded by just looking at a ECG. Right here, come here. Right, where you are seeing ST elevations here? Can anyone tell? Just briefly look. ST elevations are seen in lead 1 as well as in AVL, as well as few subtle ST elevation in case of V6 as well. That is only just more than 1 mm. So we are seeing ST elevations in 1 AVL as well as V6. Therefore, lateral leads, we are seeing ST elevations in lateral leads. This is known as lateral wall STEMI. Correct? This is lateral wall ST elevated myocardial infarction. I told what? If there is a lateral wall STEMI, which arteries are actually occluded? Only lateral wall diagonal branches. Correct. It could be due to occlusion of diagonal branches, obtuse marginal branch, or ramus intermediate artery. Correct. Okay. Let's look at another ECG. Look here. ST elevations are seen where? V2. Correct. V3. I told there is ST elevation, physiological ST elevation also seen in V2 and V3 up to 2 mm in males more than 40 and less than 40 up to 2.5 mm. Right, is physiological ST elevation. Then how to differentiate whether it is a physiological or pathological? I told just shortcut to look is look in the lead V1 and V4. If there is ST elevation in V4 or V1, it is pathological. Look here, there is ST elevation in V4. That means it is a pathological ST elevation that is seen only in ST elevation is V2 to V4. That is only in anterior leads, right? Therefore, it is a case of anterior wall STEMI. Anterior wall STEMI. What is the site of what is the artery that is occluded is LAD. What is the site that is occluded is distal LAD. That is distal to the diagonal branches. Distal LAD occlusion. Okay. Now, let's discuss regarding the RCA. That is right coronary artery as well. Right. To discuss the right coronary artery, you should know regarding the sternocostal surface of the heart. This is pulmonary trunk. Right. This is the right ventricle. Right, here we have the RA, here we have the LV. Right, this is pulmonary trunk. Right, this is RV, this is RA, this is LV. Okay, this is pulmonary trunk divided into right and left pulmonary artery. This is RA, this is RV, this is LV. So sternocostal surface of the heart is formed by this again MCQ, that is RA, RV and LV, but not by the LA. LA does not form the sternocostal surface of the heart. Out of which chamber is predominantly forming the sternocostal surface? By looking at the diagram only we can tell this is RV that is predominantly forming the sternocostal surface. Here we have the grooves. Here we have the anterior interventricular groove between the RA and RV. Here we have the anterior interventricular groove between the RV and LV. Right. Here we have the posterior. This is posterior atrioventricular groove. This is posterior interventricular groove. RCA, right coronary artery is present in the anterior atrioventricular groove like this. Right, and runs downwards in the anterior ventricular groove, then winds around the heart, enters a posterior atrioventricular groove, ends by anastomosis in the LCX. I told LCX also enters into the posterior atrioventricular groove, supplying the inferior wall of the heart. Right, these two structures supplies the inferior wall of the heart. Okay, before winding around the heart, it also gives us one right marginal branch that's supplying the RV. Right, in the posterior interventricular groove, we have one more artery. This is known as PDA, that is known as posterior descending artery, usually a branch of RCA. Depending upon the origin of PDA only, we have cardiac dominance. Usually arises from the RCA, that's why right cardiac dominance is common. Right. So this, what is the first branch of RCA by the way? We have the right conus artery supplying the SA node, RA, RV and a AV node. Right. And it supplies the inferior wall as well. Suppose if there is RCA occlusion, what will happen? Blood flow to the RA is impaired, RV is impaired. This will produce right ventricular myocardial infarction and also SA nodal dysfunction and AV nodal dysfunction. That's why the patient will classically have bradycardias. Okay, bradycardia. ST elevations are seen where? Inferior leads. What are the inferior leads? Lead 2, 3 and ABF. These are the inferior leads. I told what? Inferior wall MI could be due to LCX occlusion or RC occlusion, but most commonly due to RC occlusion. How to differentiate between them? By looking at ECG also we can tell. If the ST elevation in lead 3 is more than that of lead 2, it is RC occlusion. If ST elevation in lead 2 is equal to lead 3, then it is LCX occlusion. Or if it is associated ST elevation later leads as well, then it is also LCX occlusion. Okay, let's discuss this ECG. Where you are seeing ST elevations here? Inferior leads, correct? Look, lead 2, lead 3, V6, V5, right? That means infraposterior. Classically is a case of LCS occlusion only. And moreover, look here, ST elevation in lead 2 and lead 3. The amount of ST elevation lead 2 and lead 3 is same. That is lead 2 is equal to lead 3 ST elevation. Therefore, it is a case of LCX occlusion. That is inferior wall only, inferior wall STEMI only, but LCX occlusion. It is left circumflex artery occlusion. And moreover, we are also having ST elevation later leads, V5, V6. And also we are having posterior wall STEMI as well. Of course, I will discuss regarding the diagnostic criteria posterior wall MI. Here we are diagnosis infero-posterior lateral MI. Secondary to L6 occlusion, left circumflex artery occlusion. What is the diagnostic criteria for the posterior wall MI? R by S ratio should be more than 1 in case of V2 and V3, and there should be horizontal ST depression and upright T wave. Look, everything is there here. Right. Here we have the R by S ratio more than 1, right? And also we are having horizontal ST depression, and we are also having upright T wave. Okay. Come to the another ECG here. So what we are seeing here? Look here, V2, V3, R by S ratio is more than that of 1, horizontal ST depression and upright T wave. Right. This is the case of posterior wall STEMI. Posterior wall STEMI, probably due to PD occlusion, that is posterior descending artery occlusion. By the way, this R by S ratio is more than of 1. This R wave is actually, what we are seeing is anterior leads. But what is actually happened to the patient is posterior wall infarction. So in the anterior leads, what we are seeing is reciprocal changes. So this R wave dictates what? Q wave in the posterior leads, right? This horizontal ST depression suggests posterior leads ST elevation, and this upright T wave suggests T wave inversion in the posterior leads. Okay, how much ST elevation is required in posterior lead is 0.5 mm. In rest all it is 1 mm. Okay. Look here, another ECG, same. ST elevations are there in lead 2, lead 3. But look here, the amount of ST elevation in lead 3 is more than of lead 2. That means it is inferior wall STEMI only, but secondary to RCA occlusion. Okay, what else is also there in the for the patient here? Can anyone tell? Look here, there is ST elevation in V1, V2, and ST elevation V1 is more than of V2. That means it is a case of right ventricular myocardial infarction. Okay, why not is a wraparound LAD occlusion? This is for the MD people. Why not is a wraparound LAD occlusion? That also produces ST elevation in antro inferior leads. Here also having antro inferior lead, right? Suppose if we are getting progressive ST elevation in the anterior lead, that is wraparound occlusion. That means ST elevation in V1 is less than that of V2. Then we call it as wraparound LAD occlusion. But here the ST elevation in V1 is more than that of V2. That is right ventricular myocardial infarction. What is the most sensitive lead to detect a right ventricular myocardial infarction, by the way? It is V4R. Okay, this is also an MCQ. Please do subscribe the channel. Don't forget, and do comment. If any topic is there, I will explain. Okay, thank you.